Okay, you can turn on your microphone. Madonna will be the moderator of today's conference.
Great.
Thank you. Thank you.
She's a last year neurosurgery resident in Georgia.
Hi.
Okay.
Welcome again. Good evening, good afternoon, and good morning, wherever you are in the world. Welcome to our online conference today or tonight. Before giving the floor to our dearest guest, Dr. Amy Moore, I want to introduce our team. I'll be the moderator of today's conference. My name is Madonna Ahobadze. I'm a last year neurosurgery resident from Georgia, Sakartvelo, and I'm also a PhD student in here, Tbilisi, capital of the Georgia. A couple of words about our online education meetings. They have started with the Professor Hasan Kamil Sucu, who is present here. Shout out to Dr. Hasan. He is the program manager of the neurosurgery department of İzmir Atatürk Training and Research Hospital in Turkey. And those lectures go on with the contribution of all the residents and also with the contribution of all the neurosurgeons who have graduated from the same department, and also neurosurgeons and neurosurgery residents from nearby countries such as mine, Georgia, Sakartvelo, Bulgaria, Pakistan, Kazakhstan, and many others. Now, about the rules of today's meeting, all the microphones will be turned off during the presentation of the lecture to avoid any voice or noise pollution. You can ask your questions by writing them in the chat part of the Zoom program, and I assure you, at the end of the presentation, your questions will be asked to the lecturer, and all of them will be discussed accordingly. So mutual discussion is not appropriate for the format of our meetings. And before we start, of course, I would like to introduce our dearest guest. It's my distinct privilege and honor to present Professor Amy Moore. She's the chair of Department of Plastic and Reconstructive Surgery at the College of Medicine at the Ohio State University, and she's an expert in peripheral nerve reconstruction. Prior to her move to Ohio State, Dr. Moore was Associate Professor of Surgery, Chief of the Section of the Hand and Trauma Surgery, and Director of the Hand, Nerve, and Microsurgery Fellowship. Dr. Moore received her medical degree at the Virginia Commonwealth University School of Medicine and completed her general surgery residency, peripheral nerve research fellowship, and lastly, plastic and reconstructive surgery fellowship at the Washington University School of Medicine. She then completed a hand fellowship at the Mayo Clinic. As a committed surgeon, I would like to add she is also a scientist, because Dr. Moore has developed a parallel translational science research program with more than $1 million in funding from the Department of the Defense. And she has extensively published her clinical and translational research findings with more than hundreds of peer-reviewed journal articles and also the chapters in the textbooks. Her dedication to her field is manifested in her service and leadership roles on the national and international associations and boards. She serves on a scientific advisory board for the International Symposium of Neural Regeneration and has participated in multiple study sections. She is a passionate educator and tireless advocate for her fellows and residents. She has lectured at the conferences around the world, and she's with us today, and it is my distinct privilege and honor to present her once again. So Dr. Moore, the virtual stage is yours. You can share your screen now.
Thank you. Awesome. Thank you, Madonna, and thank you all. And San, thank you very much for the introduction and for allowing me to speak today on what I love, which is nerve transfers. And thank you for listening to that long introduction. And I'm sorry, it's what we can do, but it is who I am. So today we're going to talk about nerve transfers, and I love that we're going to cross pollinate our disciplines, because in the end, no matter where we are in the world, we are going to speak the same language, and that's the love of nerve and nerve surgery. I have a few disclosures that are relatively new, and it's always good when you have some disclosures because it means you're trying to make something. And then I do want to acknowledge my patients and their parents of some of the kids so I can tell their story, and they've given me permission to share their videos and photos. A little about me, which we heard about, but I'm now living in Columbus, Ohio. It's still considered part of the Midwest. I did most of my training in St. Louis under the leadership of Susan McKinnon, and then went and worked under in the Mayo Clinic under Rob Spinner, Alan Bishop, and Alex Shin. And then have now found my way to Ohio State in a much larger leadership opportunity and building a nerve center here. My clinical practice is complex nerve. It's 100% nerve. And I treat a lot of patients with pain, with injury, post-viral syndromes. And I like to refer to it that I'm sort of a Hail Mary surgeon. And in the US, the definition is as written below, but a typically long unsuccessful pass made in a desperate attempt to score late in the game. And when we think about our patients with nerve injuries, we all know who we're talking about. We're talking about the patient who's showing up just on that edge from when they had their injury, or they're coming with something super complex and who else is to do it. And so they've seen multiple practitioners before me. So when we think about, nerve and nerve regeneration, I think it's important for us to be on the same page. And I know we have different levels of trainees and learners. And so forgive me if this is way beneath you, but I think it all is important for us to talk about it. After a nerve is injured, the peripheral nervous system, unlike the central nervous system, loves to regenerate and at least to search for its target, which is either the muscle or skin or visceral system. The neurons, which are held in the spinal cord for motor or in the DRG, dorsal root ganglion for sensory, extend its axons out. And it's the activity and changes that happen at the neuron that allow the axon to regrow. And this coordinated of events are essential for allowing us to capitalize on this power to improve motor and sensory function. We say time is muscle, and that's because most of our focus with peripheral nerve injuries has been on what we can restore with motor function. And we like to say about the muscle, but there were great studies that showed that there are changes also at the nerve level if nerves have been denervated over time. And that is that the Schwann cell's ability to support regeneration diminishes over time. And so we need to be addressing both. We need to address those simple cells, those motor implates in the muscle so that they don't undergo irreversible atrophy. But we also need to think of ways of avenues of being able to preserve the nerve and those cells at the distal nerve as well. And so when we think about what are our limitations with nerve surgery, it's that we have very slow regeneration, millimeter a day, inch a month, foot and a half a year. So if we have an injury up at the neck, it's going to take 2 years before the injury regeneration hits the hand. And that's too late because those cells have undergone irreversible atrophy. And so we're up against this regeneration rate. There's been a paradigm shift of how we treat patients with brachial plexus injuries. And today we're going to talk about the upper extremity as well as the lower extremity, given that I'm sure you as neurosurgeons and those doing nerve surgery deal with both. And as a plastic surgeon, I have been fortunate to be able to also treat both. So our paradigm shift is to nerve transfers, and that's because we were getting only satisfactory results from nerve grafting of the plexus. It doesn't mean that nerve grafting of the plexus is obsolete and that we shouldn't do it, but it's the idea of what else can we be doing. And so nerve transfers, by definition, is taking a donor nerve that is expendable, redundant, synergistic, to the recipient, and we cut the nerve and then transfer it, rewire it to the recipient nerve of a muscle that has more important function. By doing this nerve transfer, we effectively decrease the regeneration time because we're closer to the target. We don't need a nerve graft because we can control the tension, meaning donor distal, recipient proximal, so that there is no tension on the coaptation. And you don't have to operate in a scarred bed because, again, you can be outside of the injury site and closer to your target. And so when we think about nerve transfers in the 1990s, Christoph Oberlin and Susan McKinnon published their studies on nerve transfers for elbow flexion. And there have been nerve transfers described for decades and years, but it wasn't until the 1990s that I think we were at a place that we wanted more for our patients and that nerve mattered. And from that point on, you can see there is an exponential shift and interest for nerve transfers. Why did it stick? Well, it seems to be that looking at meta-analysis and systematic reviews, that nerve transfers, when looking at the brachial plexus population, they produced better outcomes than nerve grafting alone. And so because of the enhanced benefits of recovery, nerve transfers are here. And then we started pushing nerve transfers into the upper extremity, not just for brachial plexus, and also into the lower extremity, which I've had a privilege to be one of the pioneers. When we think about why is a nerve transfer giving us better results, it comes back to, I think, a study here by Tessa Gordon, who is one of my heroes. She is a neuroscientist working out of Toronto, but did many years of work in Edmonton, Canada. And out of her lab, she showed if we take away the motor neurons, it took up to 70% of denervating the motor neurons at the spinal cord before a functional loss was seen in the animals. So that, in other words, means you only need about 30% of the muscle to be reinnervated to get back up on the hill and have function. And so when we think about what we're trying to do with nerve transfers, we're rewiring enough motor neurons into the muscle to give us function, because we know we don't need 100% to do that. But then we have to combine our strategies. And a good friend of mine, Jamie Bertelli, who is from Brazil, and many of you, I'm sure, know, have heard of him. He keeps us grounded in saying that, you know, we can't just focus on nerve transfers. We need to get the best outcome, be able to combine strategies. And so this is very, very common in my practice, where I will graft for pain, I will graft for proximal restoration, and then I will do distal nerve transfers for augmenting function. And that combination has worked well in my hands. And so when we think about why and what and how we do it, it all comes back down to our patients. Our patients are what's driving us to do better. And I will tell you about most of these patients today. When we think of nerve transfers, we can do them everywhere, from facial reanimation into lower extremity. And we're going to focus on a few to give you more of concepts, much more so than a complete categorization. We don't have enough time to go through all of it, but hopefully we'll have time at the end that we can discuss specifics as needed. So when we think about the published literature, the upper extremity is where the predominant experience with nerve transfers reside. And for the most of these publications, it's within the brachial plexus. And slowly we're moving into the high nerve injuries. High nerve injury means above the elbow, but not at the plexus. And usually those are isolated to one or two nerves. And prior to nerve transfers, we did tendon transfers for them. So in the upper extremity, brachial plexus, of course, we know our priority of reconstruction being elbow flexion, shoulder stabilization, and then hand. And in the baby population, which is what we'll not speak of, this is reversed. However, with elbow flexion, we learned again from the two giants of nerve transfer surgery, Oberlin and McKinnon, that we can get inside the nerve and find fascicles that can direct it to our wrist flexors or our finger flexors and transfer them to the biceps and brachialis. And so with a double fascicular transfer using both the median and the ulnar nerves, we can dissect into the nerve safely and identify the fascicles that have redundancy and synergism with elbow flexion. And I like to show my residents, and I make them draw two circles, thinking of that each are the median and ulnar, and the fascicles are looking at each other. And so we go to this googly eye photo, because this is a visual picture of where we don't need to be dissecting through the entire nerve. We can go directly to where we think the fascicles will be. We make sure we stimulate intraoperatively for the fascicle redundancy. And then I know I'm leaving behind plenty, and I take what we need. I like to take FCR to brachialis and FCU to biceps. We know that there's redundancy in this fascicles, and patients wake up without any motor deficit. The FCU goes to the biceps, and it's a bit of a stretch, so you have to get length on your recipient. But I don't like the idea of having the median nerve, which also does pronation, to also be my best supinator. And so I really am stick to median goes to brachialis and ulnar goes to biceps. And when we think about outcomes, we can get great results. We can get great results for C5-6, C5-6, C5-6-7, and really strong elbow flexion with very little need for therapy. I mean, all of our patients take time to get their physical therapy and hand therapy, which is not to be diminished, but this is so synergistic. It also is not dependent on the size of the patients. And so there's a lot of, talk about obesity in the US, and that patients who have, higher BMIs have worse function. Well, I can tell you this is not a contraindication in my hands. I do not use BMI as a distinguisher, nor do I use age. I think we have different expectations. Patients may have wound healing issues the larger they are, but their nerves will reinnervate. And so when we think about brachial plexus, there's many other nerve transfers that can be done. But for today's talk, I'm going to move on to give us other ideas within high nerve injuries and then into the lower extremities. So when we think about high nerve injuries, we want to think about isolated nerve injuries because that's a little bit more simplified. There are strategies when we can have if one or two are out, but let's talk about the radial nerve. So the radial nerve transfers is one of the most it's the most controversial for sure, because tendon transfers are great. But then let me tell you about a patient, and maybe you understand why I tend to favor these in the right patient. So here's a 35-year-old ICU nurse, right hand dominant. She's into CrossFit, so very, very fitted. Totally muscular. She had an axillary mass biopsied, which came back as the schwannoma of the radial nerve. Horrible pain. This woman was in horrible, devastating pain and without any radial nerve function high up in the axilla, including her lack of triceps on her dominant hand. This is a devastating injury for her. So I took her to the operating room, identified, the stump of the radial nerve and found that it was completely tied off, and then decided I was going to reconstruct it using thoracodorsal to her triceps, because triceps are very important for stability as well as her access. And so I did thoracodorsal to triceps. I grafted for pain and proximal reconstruction, because the radial nerve is one of the nerves that loves to regenerate. And so if I can get anything proximal, pain and sensation be controlled, I graft. So I grafted with her sural nerve. I did a anterior branch of the thoracodorsal to her triceps branches. And then distally, I performed nerve transfer. FDS goes to the ECRB, and FCR goes to PIN, synergistic. And so here at 1 year, here's her triceps coming from her thoracodorsal. Here is her fingers, which is just at a year. It takes a long time to do this nerve transfer, but by 2 and 3 years, she's back at work within a year at her ICU, back working out clearly, as you can see. But very natural reconstruction of her fingers, thumbs, and wrist extension. And at 4 years, she sends me, this is her triceps. I'll remind you, her injury is on the right side. And I can't even do this at all. So this is so hard to do, much less having a devastated radial nerve injury near posterior cord. So that is why we do nerve transfers, because we can get some pretty miraculous results. Ulnar nerve. So the ulnar nerve is one of my favorite nerves. And this is because it is one of the most devastating functionally for our patients. And so here's a young patient who has the discoordination of that right hand. She fell through glass, lacerated her ulnar nerve way up at the axilla. And we know that kids love to regenerate, right? They regenerate a bit faster, 3 to 5 millimeters a day in comparison, are 1 to 3 and the adults. And so important to take her to the operating room. So here's another patient with an equally devastating injury. This gentleman, MVC rollover, had complete avulsion of his radial nerve from the muscle bellies. And so he has no radial nerve, and he had a large segment of ulnar nerve that was avulsed as well. And so what do I have as an opportunity to treat both the nerve, muscle, and the nerve? And so this is where the supercharge reverse into side nerve transfer can come into play. So by definitions, again, traditional end-to-end, donor into the recipient. A traditional end to side is taking the recipient to the side of a donor, make an epineurial window, and allow the donor axons to collaterally sprout into the recipient. This is left mostly for sensation, and sensation in non-critical parts of the hand when we would do a regular into side. A reverse into side is different. It is finding an additional motor neuron source, and we take the donor nerve to the side of the recipient through an epineurial window. You scrape on the fascicles, you don't injure the fascicles, you let the fascicles come to you, and you bury the nerve into the side. And we know with regeneration, Schwann cells will go into a denervated nerve. Schwann cells go in that are healthy, helping the nerve environment, and then the axons grow through. And so we showed this in our laboratory, proof of concept that you can get regrowth into the distal nerve through the side and an epineurial window. We put it into an injury model with a graft, and we showed with muscle force analysis, augmentation of function, even when we transected the contribution. And this is because both the environment and the connections made. There's a misnomer and people call it a babysitter. It's not a babysitter. This is a live-in nanny. This nerve transfer does not go away. These are functional connections. We did retrograde labeling. I don't know if I have a picture of that, but we did retrograde labeling showing that there was a majority of significantly more motor neurons with the supercharge. And so that's trying to get us back on the hill. If you remember, you only need 30% of the motor neurons making functional connections to get your function. And so this is an opportunity to use it. So with this, the girl, the 7-year-old who fell through the door, took it to the operating room. I grafted her ulnar nerve proximal for pain and for any type of proximal reinnervation we could get. And I did a supercharged distally because she was 7 and had very much the potential to recover. We saw what she was preoperatively and postoperatively. She has the result, again, is on the right hand. It's not perfect. She continues to get better. But you can see that she has good control in comparison to what she had before. She's not clawing. She can hold her intrinsics and continues to get better. The gentleman, the 48-year-old, here he is, 7-centimeter sural nerve grafts at the elbow, transposed, and then a distal supercharge. And he doesn't have radial nerve, but if you watch his ring and small finger, you can see that he has intrinsic function. Again, devastating injury, high, 7-centimeter graft plus a supercharge. We looked at our patients at Washington University, and we showed we can increase their hand strength with no donor site morbidity. Now others have also published similar aspects. And so this isn't going anywhere, but this is a tool that I encourage others to use. When we move into the lower extremity, we're talking about a much smaller group, a much smaller avenue of what people are doing nerve transfers. And this is where I'm grateful for the opportunity to show you options that we do have as well. And that is within, both sciatic as well as in femoral nerve injuries. So when we think about the lumbar sacral injury of this patient, a 14-year-old, 6 months prior to his presentation, he had weakness of his hamstrings and nothing below the knee. As he is ambulating, you can see he has to flick. He has only femoral nerve function present. He has a waddled gait because his gluteal nerve has also been affected. And so we took him to the operating room. Because when I was at Washington University in my residency, we demonstrated that we could restore femoral nerve function using the obturator, distal obturator, as well as the tensor fascial lata nerves. And then when I went to Mayo Clinic, I had the experience of, okay, well, I know what the femoral nerve anatomy is. Here we're going to use scaphoid non-unions. We're going to do a vascularized medial femoral condyle. But in the process of us dissecting this bone flap, I saw that there were these little nerves of vastus medialis, and found that the femoral nerve reinnervates the vastus medialis along its entire length. And there's 2 large branches that enter into that distal segment of the muscle that we can use closer to the target than as a donor. And so our focus is to restore gastroc muscle function. The gastroc below the knee allows the brain to have feedback, and you all can probably tell me more than this than me. But when we looked with our gait specialists, this is what they recommended, us trying to reinnervate below the knee. And so we used both the medial and lateral gastrocs, neurolysing them, passing them through the thigh to the vastus medialis branches, which are present there. We can do direct end-to-ends for vastus medialis. And then vastus lateralis terminal branches are also exposed, but this requires a nerve graft. And so the nerve graft goes from there. The young kid was back playing basketball on a varsity level. This is a second patient who demonstrates, has no toe up, but is able to push down. And then another gentleman who was a football player that had femur fractures and avulsed his sciatic nerve, but you can get some early result around 10 months where that is enough to get these patients back with an AFO running. We were able to publish this as well. So when we think about, okay, what about the femoral nerve, the sciatic nerve, that's really the only one I have for sciatic nerve, is to restore gastroc. Everybody asks me about perineal nerve and what we can do for the perineal nerve. These nerve transfers would work for that as well. But I will tell you the AFOs are so good, and the reinnervation of the perineal nerve is so bad. You can have a sharp transected perineal nerve and you can repair it and you still get very poor function. And so I think that, just like the radial nerve wants to recover, the peroneal nerve does not. And so I focus my attention on the tibial nerve reinnervation and less on the peroneal nerve and get them into a good AFO. Femoral nerve, here's partial nerve palsy. This is a gentleman who was a marathon runner, ran his fastest half marathon training for the Boston Marathon, developed a psoas hematoma and compartment syndrome, and shows up 4 months and has this on his exam. And I'm like, oh, he's recovering. His rectus femoris is there. He's going to get these others. They're going to come back. Except at 6 months, he shows back up and he still has no recovery on his motor units for his EMG. So at this point, I said, okay, well, he has a partial injury. Maybe when they went in to release his compartment syndrome, they partially injured the femoral nerve, and I can do the nerve transfers because I learned, that the obturator to femoral nerve transfers do great. And so the issue here, though, we went back to the supercharge is because of when I got into the operating room on this patient, and decompressed his femoral nerve. And I think decompression of the femoral nerve is an underutilized procedure. And I decompress femoral nerves very frequently, and I'm very aggressive about it because it can help with patients' pain and it can help with recovery. But I decompressed his femoral nerve, and when I used handheld stimulation, his muscles were firing. And so I didn't believe it. And because I had that EMG that showed nothing the day before. And so I made this cut distally into the muscle to confirm that what I was stimulating was actually the muscle firing. And so at this point, I'm not going to cut what's recovering. And so then it was like, well, I already have my donor ready to go. So I used the obturator to gracilis and transferred it over. And you can see this is just a scarred bed of mess. But I transferred it plus sartorius branches that were also firing to the non-working nerves. And here he is 2 years post-op. He's back running. He's actually 4 years now and ran his marathon just recently. And I won't go more than a 5K with him, but he's coming for us to do one in the spring. And we were able to demonstrate that also and get it published. So the femoral nerve, which is exciting for me, came from studying patients with acute flaccid myelitis. And towards the end of this talk, I'll get back to that. But here is a gentleman who had an oncologic resection of the femoral nerve. So this is at this preoperative in the holding. We are getting ready, and he's at time 0. So there is some femoral nerve functioning. But when we go to the operating room, they take this big tumor and they have a 10-centimeter gap. So again, using what we have, I grafted, which is just covered in blood here, so I apologize, but I grafted 10 centimeters using a sural nerve for pain because he had horrible pain. And then I used the obturator, which was maintained. I used obturator to rectus femoris because rectus femoris has the shortest distance. And then I used fascicles of the sciatic. And so this is just like how we used fascicles of the median nerve, fascicles of the ulnar nerve. I used fascicles of the sciatic to restore vastus medialis and vastus intermedius. And so here he is, 6 months, 8 months, and at a year without a knee brace, without anything, and can go differentially up steps. He does not like to go down steps. I made him hold on because it makes me nervous in people with it, but doing incredibly well. Here's another patient, same set of nerve transfers, obturator and sciatic fascicles, and she, being younger, is able to go up and down steps at 18 months. You can see the definition in her thigh. And last but not least, using only the sciatic fascicles. So here's a patient who, young, spinal cord injury, infarct, they think, from a scoliosis reconstruction, woke up without, this is her preoperative state. So left leg works great. Here's her right. She's trying to do hip flexion. She's trying to extend. She has no quads. Go and do the transfers for her. At 6 months, she's demonstrating at least some Maybe some of this came from just decompressing her femoral nerve, but demonstrating when she does her toe up that she's able to get her firing. At 1 year, same thing. This is her pre-op state on the left. This is during COVID, right? So here she is extending, using her donor to try to get it up. And then 2 years later, up and down steps, you can see that she has the return of her function. It's not perfect, and she would say it's not perfect and she wants more. But I would say it's pretty darn good from having nothing. And so I will tell you the opportunities for using nerve transfers for the lower extremity. We haven't tapped all of our opportunity. But I think like putting it global is, I want to be operating by 6 months. I can tell you that, because I think that that's gives the time for recovery the best chance. However, I have done nerve transfers, especially for femoral nerve function, up to about a year from injury. So the last topic for us is to talk about acute flaccid myelitis. And I think there's actually up to 7 now publications with regards to how we treat them. And acute flaccid myelitis, for those who may not know, it is basically the common day polio. So young kids, average age of 6 years, get a respiratory virus. They're healthy and they get a respiratory virus, and then it attacks their spinal cord. And it's an anterior horn cell disease process. They have flaccid paralysis, and was first recognized in 2014. It comes in every other year. 2020, we had very few cases. Thank goodness, because of masking and because of COVID. And we've only seen a few this past year, which would be the 22. I've probably seen and evaluated 8 kids so far, but it is devastating. 36% had lower extremity involvement. And when they came to be, I had friends at the Shriners Children's Hospital who were doing nerve transfers for the upper extremity problems, but no one was knew what to do for the lower extremity. I didn't really either, except I gave like, oh, I would want to use my sciatic fascicles for them. And the idea was there, but I hadn't had the patient population. And then my friend said, well, they're going to come to you. And so here's Brandon. Brandon is 8 years old. He was wheelchair bound and devastated from his right leg being affected by acute flaccid myelitis. And so sciatic fascicular transfers were performed because the only movement he had was within the toes. And this is not Brandon, but this is what the similar incisions would be. I ended up operating on 10 children from the 2016 cohort. But what's really cool is that up at the gluteal area, the topography is stable. So we can find the different fascicles of the perineal and tibial nerve way up at the gluteal range. So I can take toe movement to give gluteal nerve restoration. And I focus on superior gluteal nerve for stability of the hip over the inferior. And then also you can reconstruct the hamstrings. In the thigh, we can again identify the toe movement. So identify the fascicles to allow us to transfer to quads or to hamstrings. And so for gluteal nerve function, this seemed to be the most of the children needing this. It's very simple, direct end to end. Hardest part was getting down to the gluteal nerves with all those big vessels that sit with them. We can do femoral nerve function. Again, this was similar to what I did for the oncologic patients, but I had only done on children prior to this oncologic. So they were not done chronologically how I described them to you. But these are how I learned that this procedure could work. You cross the nerves through the thigh to the sciatic because you only get very short distances on the sciatic. We can restore hamstring. It's right there beside you. And easy to do for hamstring function. And so this is a little boy who had gluteal and hamstring, and you can see his hamstrings were just starting to activate, but here comes his gluteal function. and doesn't really know what he's doing to it, but his little tush is showing that he's getting gluteal function, and he squeezes his toes and his knee bends. And so this is really a really cool thing to see, because I wasn't sure it was going to work. And now here's Brandon, 2 years. He still requires bracing. We didn't restore all of the function. He has upper extremity involvement. He has core involvement, but now he's only in his wheelchair to play basketball. And so from this cohort of patients, I was able to publish, on them. We took care of 10 patients with an average of 16-month follow-up. 2 patients were walking pre-op, 8 were wheelchair bound, and 6 of the 8 are now have walking as their primary ambulation. And I will tell you, it's not MRC grade that we're restoring. It's global exercise tolerance that I think is really the impact here, not on the specific muscle group. And so my thoughts on this, and I've allowed time for us to chat, is that, what we can do with nerve surgery is incredible. It's inspiring. My patients are what inspire me to figure out, okay, what else can we be doing? What can we be doing better and get the better outcomes? I'm now really focused on sensation and what can we be doing to restore sensory function to our feet and to our hands. Rethinking about pain. Patients have pain, and if we don't ask them, we won't know and see it. And then last but not least, it's important for us to analyze our results. I have this big, huge team of research. I've actually exceeded $5 million this year from the DoD to study patients. And the reality is everyone asks why. Well, the why is so that we can continue to know what to do and to do it better. And so we're at a really great time. And thank you for having me today. It is incredible. This is my family, which also inspires me to leave the hospital at times to get home to them. And so with that, let's have a discussion.
Thank you so much, Professor Amy Moore. That was remarkable. Your cases were really inspiring. With your creative and critical thinking, I think you achieved almost impossible, and that is inspiring for all the listeners, I'm sure, for the fellow surgeons as well. I would use my moderator privileges, and I'm gonna ask first questions if it's okay, and then I'm gonna read the chat section. So I saw in some videos you use the electric stimulation. So how often do you use it? How often do you recommend, maybe not just intraoperatively, postoperatively? What is your ideas about it?
No, great. So one of my clinical trials right now is studying the benefits of electrical stimulation for regeneration. So I'm going to give you twofold. So intraoperatively, there are these devices that allow us to find the nerve. And there's a device from Checkpoint. Again, I will show you my disclosure. I am a research collaborator. I've taken no money from them, but we wrote the grant together to advance the technology. But with this device, it can provide, at 2 milliamps, 20 hertz, the electrical injury and energy to the nerve. And in the 1980s, Tessa Gordon, Tom Breschart, Art English showed that intraoperative electrical stimulation will affect the neuron and improve axonal outgrowth. So if we separate it, I use the diagnostic of using it in the nerve stimulator intraoperatively to make sure it's not working. So before I cut any nerve, I got to make sure that at 2 milliamps, it's not working. Okay, I also use it to identify my donor, to make sure the donor is strong, that it's not weak, that it has redundancy. And so that's how I use it intraoperatively. But now, after doing all of the science, and we've published now 4 papers out of our lab demonstrating with this device, we can improve regeneration in animals. And what I've seen in my patients early on from our pilot studies, I do it on any patient. So any patient with a nerve compression and weakness, they get 10 minutes of electrical stimulation.
Well, Thank
Yeah.
you so much.
You're welcome.
Now I'm going to read the questions in the chat. There are a lot of hellos from Nepal and different countries of the world. And here our female neurosurgeon from Turkey, Dr. Selim Bozdak, is asking.
Oh, I see what she asks. Okay, she just, Madonna froze.
Maybe Celine, you can ask yourself. Madonna, I think.
I can read it too.
Thank you for this wonderful presentation.
Oh.
Uh-oh.
In cases of traumatic nerve injury, as in this timing of surgery now, or are you waiting for the certain time? So my purpose in asking this question.
Madonna, we can not see you. Okay.
Oh, well, okay. Madonna, sorry, it's breaking up, but I understand the question. So we'll go to the question. So timing matters. It matters more importantly than anything else is that when did the injury or the insult happen? Viral neuritis, West Nile virus, I'm seeing patients with that. Transverse myelitis, when did it start and when is that happening? Because it comes down to knowing that the patients with spinal cord injuries regenerate slower. The patients with older regenerate slower, the younger regenerate faster. And so it's always setting expectations in my mind about when I should intervene. If I know it's lacerated, like any open wound with a nerve deficit should be explored. So in the traumatic setting of here's a stab wound, they have deficit, there's no waiting on that one. That one gets explored in my hands. If they come to me, which is more common, at 3 months, and it's a closed injury, and the patient feels they're improving, I'll get an electrical study, EMG, nerve conduction studies, and assess. I will schedule surgery by 6 months, and I can always cancel it. And so in our head, we have the hardest part in the US right now is just getting access to the OR. But I want to be operating by 6 months, whether it's upper extremity or lower extremity, if I can. Now, I will tell you, it's rare that it's not rare, but there's many patients who come that are coming later than that. If they've had their injury and they're at a year, unless they're young, I don't really often offer a nerve surgery. And you could ask me which one I would offer, like I would for biceps. I've intervened for elbow flexion because the distance is short to get there at 13 months in a 50-year-old and got great result. So it depends on what nerve is injured, if it likes to recover, the age of the patient. So it's much more complicated. Okay, so the rest of that sentence talked about 3 hours by the road, open injuries come in, should we send them to the center immediately? Should we do the open wound before the patient? So I don't know if anyone noticed, but I waited, time. You want to make sure if there is an open wound that's devastated, it needs to be clean. You're not going to put your nerve grafts into a dirty bed. So the idea is that we don't sit on the nerve injury. The idea is, okay, let's get it to a clean place, get a flap if it needs a flap by plastic surgery, and then do the nerve surgery under it. I don't think it has to be seen that night. We don't have any intervention. I'm part of a group studying neuraptive, which is PEG fusion, where it has to be done within 48 hours. And the reality of that, I don't see it really bearing out too much yet. But so I'm sorry I went off before I answered your second part. I think that being referred within the few weeks is fine. Don't ignore it though, right? So the idea of like, oh, I'm going to get EMG serially and there's been an open wound with a lack of function, assume that that nerve is injured. You don't need to get the EMG to help you. The patient can't move. Great question.
Thank you, Dr. Celine, for the question. Thank you, Amy Moore, for the answer. I've got some comments here from Hakan Karabaoğlu. Thank you very much. Professor Akol is saying, thank you for excellent presentation, Professor. What is your policy about cervical root avulsions? And
Yeah.
would you answer the question? Yeah.
So the avulsion, well, it depends on what's avulsed, and how many roots are avulsed, and if it's lower extremity or upper extremity, and how much pain they have. So the avulsion pain, and I know I don't need to tell you this, but I'm going to just tell you with you, is awful, right? So patients who have horrible avulsion nerve pain, you can do the most perfect nerve surgery, but they don't move their arm or their leg unless we get better control over the pain. So my thought process is, if there is a root available, then I'll use it. If it's distal function, so like if it's an upper trunk and they're avulsed, C5, 6, 7 even, I still have C8, T1 hand to do nerve transfers distally, and I don't go up to the neck. I'm assessing avulsions by, we have MRI, much more so than CT myelogram anymore, and to do a nerve conduction study looking for sensory nerve action potentials. But I will assess for the avulsions and then do distal nerve transfers if I don't think there's a viable route. I often explore, because when I was at Mayo Clinic, you know, Rob Spinner got into my head of saying that there's always, even if they say 5 root avulsions, there's always a root available. And I can say that I've seen that some. I haven't seen it as much as they told me I would see it, and so it's a big dissection for, you know, a less than satisfactory result. But I think that's sort of my process on it.
Thank you. Next question from Dr. From Turkey, Bektaş Acıköz. Thank you very much, Professor Emi, sharing your excellent experience with us. Could you please kindly give some information about your team, example, rehabilitation, intraoperative monitoring? Thank you.
Yeah, so just having to rebuild this. I've been at Ohio State now for 3 years. And my team is pretty streamlined now. We had a big team in St. Louis because it just had decades of us doing nerve surgery. But my team is me as the surgeon. I have 2 other junior faculty that I'm mentoring. We have a neurologist, primary neurologist, and a junior neurologist that do our nerve ultrasounds. That I tend to get along with an EMG or nerve conduction study. I have a physical medicine and rehab physician that I also use, and they tend to do more of our my thoracic outlet injections of the scalenes, Botox of the pectoralis minor for pain. And both either PMR or neurology will provide my EMG studies, just depends if they're going to them anyway. And then my rehab, I have 2 hand therapists who have taken a keen interest on rehabbing nerve. And they are amazing because they talk to other hand therapists around the country, because most of my patients get on a plane to see me. And so they're not getting their rehab here in Columbus, but they get seen one time, get their protocol, and then get therapists closer to home. I don't do intraoperative monitoring. I did it a little bit early on, looking for, you know, okay, we're going to try to do the CMAPs and all these things. And I found it just to be cumbersome and not reliable. So I don't do any intraoperative monitoring, except using that handheld device. I feel like I'm missing out. Radiologist. Oh, I have a new neuroradiologist that I found and tried to recruit. Everything is about trying to make people care, right? Like, this is why you need to do this. This is why I need you to care about this. So we're trying to get, I have a 17-year-old who had a shoulder dislocation of the axillary nerve palsy, happened playing football, American football. And, you know, trying to get an MR neurography to see, is it ruptured? Is it just compressed? Where is the injury with it? is sort of our new investigation, trying to get better imaging. So that's pretty much my team. And then I have a patient navigator and a physician assistant that helps me handle all the patients.
Thank you. Next question is from the future neurosurgeon, Afan Ahmad, who is a medical student in Georgia. Thank you for your interesting presentation. Your videos were very inspiring. I have a question. After this surgery, is he going to have every type of sensation like pain, touch, pressure, and temperature, like a normal person? If he, how long will it take to get normal sensations? Pretty tough question again.
Yeah, so sensation follows motor. And so meaning the sensory re-education of the brain, I think it's hard and continues longer. So we haven't focused much on it, right? Because it's really easy to show all these great videos of things moving, but what do they feel? And if you don't have sensation to the hand, they don't use it. So I care about sensation. It takes almost 2 years before I'll say, okay, this is good sensation. I'll do intercostals for a pan plexus, for example, and I use intercostal brachial to the lateral cord of the median nerve. And it takes 2 years before it's into their hand. And so it's never normal. Sensation is never normal after a nerve injury. You can do a median nerve at, a sliced median nerve at the wrist, and they will still not get normal, even in a young person. They will get something. Hopefully they get protective, but the sensory recovery is hard. One of our DoD grants is looking at late, greater than 1 year from injury. Can we rehab doing transcortical stimulation to prime the brain opposite to it to improve sensation? And so I think there are strategies to improve sensation, but it's never normal. And it's harder to follow. And our metrics for detecting it are awful. So we have, that is an avenue we need to lean into a bit more. But
thank you for your honest response.
Yeah,
thank you very much. Next question from Ayhan Kanat. Thank you for your good presentation. My question is not for nerve transport, but I would like to ask whether you use nerve transposition during cubital surgery. What do you think effectiveness of the transposition?
Yeah, great question. So if we look at the data, right, if we look at the literature, they will say no matter what you do at the elbow, it doesn't matter. It doesn't matter if you transpose it or if you do it in situ. So I consider myself a revision surgeon because most of the patients come for revisions. And I think most of the revisions are either through a small incision in situ, or it's rare that they're coming from ones that have been transposed, but a subcutaneous transposition every once in a while. And I will tell you in my own practice, after doing hundreds of cubital tunnel surgery, the only ones I've revised of my own, which is three, have been ones that I've done in situ and distal. And so I was doing them for pain, not for dysfunction. So patient had some kind of double crush, I'm going to release it distally and then have to come back and transpose. And so I learned Susan McKinnon's transposition, which is basically intramuscular. She has great videos on it. I don't tend to dissect the muscle as aggressive as she does, but I have never had to revise one of my own. Now, maybe others are revising it that I don't know. Totally humble to that. But so if the patient has atrophy, if they have changes on EMG, they get a transposition and likely a supercharged distally for their fibrillations if they have it in their muscle. And that's very aggressive, and I'd never regret it.
Thank you. Next question. Many thanks for your presentation. Do you think cauda equina patients with bowel bladder dysfunction could benefit from your techniques? Any future plans on this?
Yeah, so this is
ask from United Kingdom.
Oh, that's awesome. So I will tell you, there's the whole thing about the visceral, right? The organs and even in sexual sensitization, there's another level of nerve reconstruction, and the idea of being able to help control this aspect. I don't want to say, well, all I can say is I don't have the answer yet. Do I think we need to look at it? Yes. I personally don't have the bandwidth, nor do I have the specialty with me yet. I had a couple of neurosurgeons ask me here, and I think it is something to consider, but we have to have a donor that is available close enough, and I have to have access to it, right? So it has to be something where we could nerve transfer. I think it's interesting what we've learned, that we can reinnervate the phrenic nerve with a motor, taking a fascicle from C7 into phrenic and seeing that the phrenic, the diaphragm can work without being paced. There's been a couple of reports on that end. So I think it's possible. I haven't gone down that pathway yet, and I encourage you to, because I think there's a lot that we haven't tapped into with our redundant source of what's the power in that nerve. Thinking it's a pure motor, it's not pure motor. Think it's pure sensory, not pure sensory. So very encouraged by it, but I personally haven't done it yet. Great question.
Thank you very much. I don't see any more questions in the chat, but I got a couple of questions if you are not against. I think the discussion section was so colorful, and because of your great presentation and your great dedication, I think the audience caught it up. So my first question is, you go into the surgery with the specific plan, nerve transfer, but how often does it happen that you kind of change your tactic intraoperatively and you go just with decompression, and how effective just decompression can be?
Yes, so great question, Madonna. I will tell you two parts of that question. I often go in with thinking I'm going to be able to do this, and then be like, well, that didn't work, or that's not working, or the patients can compensate very well. And I think our EMGs are limited to the individual doing it. So you think, okay, that should be working, and oh, it's not working, or it's working some, and now what am I going to do? Right. So I think my intraoperative plan is why I love what I do, is because it's creative. It's thinking on the spot. There's never a moment that I've been there before, right? Like there's just not anything to get bored about, because it's thinking like, okay, well, if this isn't doing, what's that? Now I have algorithms, right? Okay, I know what's working. I take very detailed physical exams pre-op, and then I check it again in the pre-op holding. So if we did a study on how many times what I planned and then what I changed for the day of surgery, that's its own study, because I change it a lot, actually. But then intraoperatively, it always becomes, making that intraoperative decision-making by what they have. And I think that's the part that I think is most important, is that, okay, what do they need? What do they have? What can I do? I know there was a second part to your question. I forgot already.
No, about decompression. So
decompression. Yes, that's totally separate. So decompression, I just published this. Our multiple concurrent decompressions they're safe. So patient comes in, they've been walking their dog, they've had every workup, the dog takes off, they jerks their arm, and now they have this whole pain. Right? So they have pain, gunshot wounds, right? They take a gunshot through the upper, functions coming back, horrible pain. So these are the patients that get decompressed. It's a double crush. Upton and McComas, 1973, showed that if you have diabetes, cervical disc disease, you're more vulnerable to a distal compression. Same thing. If you have a proximal injury, thoracic outlet, you're going to be more likely to have compression. And it's all about the size of the nerve, the space which it goes. And so decompressions, I do them. I'm aggressive with it. I don't hesitate. I love it. It's a procedure that I will decompress and do the nerve transfer. It's rare that if they're not functioning that I decompress and leave it. I will supercharge it with something. Great question.
Thank
Thank you for reminding me.
Thank you so much. I see that Dr. Hakan Karabavuk has
Madonna,
raised a hand. Yeah.
With your permission,
Yes,
it was
sure,
a great
of course.
lecture, and there were 75 participants at some point in the lecture. I want to thank Professor Moore, and I want to hear the opinions of some of my colleagues, including Hakan Karabağlı, Bektaş Acıkgöz, Pınar Özışık, if they are available. First, ladies first, Pınar Özışık. Are you okay? You can turn on your microphone. Okay.
Hey, good evening.
Hi. Uh-oh.
Yeah, we can hear you, Professor Pınar.
Thank you very much, Dr. Moore. It is, I am a neurosurgeon, and actually I have been not doing very much peripheric nerve surgery. Actually, I am a pediatric neurosurgeon, but I really think that it is actually a big deficit in our practice, especially in the neurosurgery, and it must have been done by a team. I think including neurosurgery and the plastic surgery, physiotherapists, and especially with a good neuromonitorization, neurophysiologists and the neurologists inside the team. And it was a very inspiring talk. Thank you very much. Thank you.
You're welcome. Totally agree. It takes a team. Cannot do this on your own. You shouldn't. I mean, it's more fun this way to get the multidisciplinary approach to these patients. They need us. Pain management. I forgot that. Pain management physicians. Gosh, yeah. And neuropsych. That's the other one that we have use of now. Thank you for those comments.
Thank you.
Okay, Professor Karabağlı.
Yes. Good morning for you, Dr. Emi. Thank you very much for your good lecture. I have two questions. First, do you have any experience about gunshot nerve injury? I mean, high velocity nerve injury. I mean, military gunshot nerve injury. Do you have any experience? Second question: after or before nerve injury, do you have any specific, before the surgery, specific medical treatment, drug therapy? Do you have medical treatments? Do you have a protocol?
Great question. So the second one, the protocols for preoperatively or perioperatively are all around pain control. You know, there's talks of like, okay, could you give them zinc, vitamin C, or even tacrolimus was brought up. You know, I don't do any of it. I don't do steroids either, which, I mean, unless they're having an acute pain crisis, then I'll get steroids involved. But I know that others have, and then using testosterone to help speed in the perioperative space. I personally don't have any of that in my project and in my practice currently. But I recognize the science behind them and think it's possible. But a lot of my patients don't want the side effects that could come from those. As for gunshot wounds, so St. Louis, Missouri is ranked usually in the top 3 of all gunfight and gun warfare in the US. And I happen to be working for 10 years there as the hand surgeon. And so every night of call, we would get multiple gunshot wounds, high velocity gunshot wounds, blasts, AK-40s. You're like, what are they doing in North and East St. Louis? So my experience comes out of these patients. Most will recover. The nerve gets out of the way. I would say 70% are going to recover. Areas where gunshot wounds become more problematic is at the wrist and near the elbow, where the nerve doesn't have space to move. If there's a fracture associated, you'll find that the nerve is damaged, but that it's in continuity. And so I think from the big military blasts, if there's a huge soft tissue deficit, right, where the nerve's going to be injured. And that should be explored. But these nerves that usually in the evidence of it, like in and out, or the posterior blast wound, but the entrance wound was small, those nerves are usually fine and will recover. I don't get an EMG in these patients until at least 5 months. I don't intervene surgically till at least 7 to 8. If it's closed in that kind of gunshot wound, because it takes that much longer for it to recover. And they recover very well if they're going to recover. And it sounds crazy, but it's true. And I think if you can explore the wound at the time, if there's your colleagues are there looking at this big soft tissue wound, it's so much easier to see that nerve incontinuity and or tag it, tag the ends if it is not in continuity, than it is to come back in through the scarred mess. Because that's the one thing those bullets do, is they create an incredible area and zone of injury. And you can't do the reconstruction the time of, because it takes about 3 weeks to develop the neuroma or the nerve injury to know that you're cutting outside the zone of injury. So that was a lot of wording, but like from the point of, if it's not a huge deficit that you can explore, I wait. I follow with EMGs. I don't get my first one before 5 months.
I see, thank you.
If it is there, the time of injury, I tag it. I get soft tissue coverage, I clean it, and then I come back at least 3 weeks, because then I know I'm grafting outside of zone of injury.
Thank you.
Yeah, great question.
Lastly, Professor Açıkgöz, would you like to say something?
Thank you very much, Professor Emi. Thank you sharing your great experience. Amazing. Thank you very much. And if you have, if you need some rest and holiday, please come to Antalya, Turkey. You're welcome always.
Thank you so much. And I hope too, right? Like, I think that sharing the good news of what we can do with nerve across the world is such a privilege. It is such a privilege to love what we do and to do what we love. And so thank you for this opportunity, because it just drives us to do more. And I love that. Cross continents, huh? So great.
And I also thank İzmir Online Neurosurgery Group, Professor Suju, giving us the chance for us to hearing you. Thank you.
Yeah, thank you all. It's great.
This is number 302nd lecture, and it's been incredible.
No, you are wrong. 304.
Fourth? Oh.
304. Come on, Madonna. 304. How amazing for you all. Like how great for COVID to provide this platform, right? So like, I mean, I know there's a lot of things bad, but I do think that congratulations to all of you and to all of you who participated. It's great.
Thank you so much.
Love it.
Thank you.
Wonderful. You guys have a great day. Cheers.
Bye.
Bye-bye.
Thank you very much.